A topic which is a bit, outside of domain of most of all of us, because they are more of a cardiac surgeon's domain, but it's necessary for all of us to know a bit about the basics. So even though we are not going to operate them unless we are a cardiac surgeon or a vascular surgeon, but we should know how what causes them and how to identify them, so that we can quickly identify them when patient present with that condition in the ER. So a lot of my lecture is based on the recent guidelines by the American Heart Association in 2022 about handling aneurysms and making protocols for treatment of that. So now, if we just a brief about when we talk about the aortic anatomy, we know just like any artery, it has a layer of muscle known as the media, uh, surrounded by an adventitia and an intimal lining. Majority of the medial lining is made of smooth muscles, some elastic lamellae, and the connective tissues are there with an elastic membrane both outside and inside the medial layer. And it is at this connective tissue level that defects occur and lead to formation of conditions like aortic aneurysm. So, people have divided aorta in many differentiations. Like all know, we have a root of the aorta, we have an ascending aorta, we have an arch of aorta. Okay, okay. We have an arch of aorta. We have the descending thoracic and the descending abdominal aorta. Abdominal aorta is the most common site where we tend to find aneurysms. They are the more common regions. And the standard definition of any aneurysm is that the size that is expected in that region, if it is more than 1.5 times the diameter, we categorize as an aneurysm. But if we are talking about the root and the ascending aorta, we are the broadest part of the aorta, so we do not usually have that regulation. We use a standard size of 4.5 centimeter or more for these segments, the root and the aortic one. Rest, it is divided into segments of 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 4, more so for radiological and surgical identification and planning purposes. For patients, we see in the later slides, for patients who are more than 2 times standard deviations of the mean height or the body surface area, we like to use different other parameters like aortic size index, the aortic height index, and the cross sectional area to height. So, what is an aneurysm? Very simplistically speaking, any abnormal dilatation in a localized area of a blood vessel, any blood vessel, not just the aorta, you can have a peripheral blood vessel also, due to a weakness in the vessel wall, is an aneurysm. That is the basic pathological definition that we see. And the abdominal aorta, as I told you, is the commonest site, which might be very asymptomatic, very incipient in progression, and might be discovered as a coincidental finding. So the most common regions, as I said, are the abdominal aorta in different part of the eye, and some areas secondary to that is the thoracic aortic aneurysm that can occur. Okay. If we talk about the general risk factors, largely it is attributable to features like history, especially family history. If you have a family history or certain genetic conditions, as we see in the later slides, you are more prone to have aneurysms. Smoking, males tend to have it more than females. Hypertensives, patients with syndrome X, that is hyperlipidemia, elderly, Caucasians, they have a risk of having such aortic conditions. In fact, diabetics have one blessing, that they have a lesser chance of getting of aortic aneurysms, because the aorta is generally thicker than non-diabetics. So as I said, the causes can be primarily congenital. Especially, we know very famously the Marfan syndrome, where there's connective tissue disorders are there. The ED syndrome, the Turner syndrome, and certain other genetic conditions predispose an individual to congenital abdominal aortic aneurysms or aortic aneurysms. Certain mechanical or iatrogenic procedures, post-stenotic or AV fistulas, especially for this is more for peripheral aneurysms. Any trauma, okay, infections, very famous. We all must have heard is when We have mycotic aneurysms. These infections can cause the fungal and the spirochetal ones especially in the earlier times when the treatment for the diseases were not that much available. People used to end up syphilis and with directly aneurysms. Then Kawasaki's and Takayasu's giant cell arteritis, some rare cases in pregnancy and post-surgery can end up with such condition. So clinical presentation mostly is asymptomatic, where you find during looking for other key reasons, other diseases, the patient has come and you find that the patient has aneurysm, or you have a surveillance program like certain countries have. You might find on a regular screening that the patient has aneurysm. If it's symptomatic, it's bad news. Okay, mostly it means that either it's expanding very quickly, causing pain, or it has ruptured, leading to pain, hypertension, and pulsatile abdominal mass on the classical triad, or it is causing erosion or compression of surrounding structures like the urethra, hydronephrosis in the abdomen, really entering into the bowel. As you can see, it's gone into the gut, or in cases it's in the chest, and mediastinal compression and invasion of the surrounding structures. Okay. If it is ruptured, mortality is more than 80%. And so many patients just can lead to a sudden death. And the greater the size of the aneurysm, the greater are the chances of rupture within a given year. Okay, so with that background, let's go to the classification. The thoracoabdominal aortic aneurysms are classified in different ways based on their anatomy, where the area is. One is the Crawford classification, which predicts the mortality and mortality based on the location. So, based on the location, it has categorized as category extent 1, 2, 3, right up to 5. So, 1 is between this the left subclavian, okay, and above the celiac axis. So, it's extended from this to this, okay. If it goes right to the iliac bifurcation from the subclavian is category 2. If it comes below T6 up till the infrarenal region, okay, then it's category 4. If it is below the diaphragm, T12, above the iliac bifurcation, it's category 4. And it's just below the T6 till the kidneys, till the renal arteries, it is category 6. Extent 6. Extent 5.